hard to think of a better, location, of a better day. It's a beautiful sunny day at sunset with many amazing people in front of us joining us. But I do think the magic ingredients of all of this is all of this crowd, of course, but also our amazing invited speaker, our first invited speaker. An applause for the invited speaker. And
first one. It's a milestone.
We could spend the entire podcast just introducing him for all of the titles he has. I tend to call him Giuseppe, which is hard enough to spell. But Giuseppe Curigliano really is, I think, an incredible mastermind of breast oncology and oncology overall. He has been my first mentor. I trained with him in Milan. I had the opportunity of training in the early drug development division of the European Institute of Oncology in Milan with Giuseppe. And beyond that, he was an incredible mentor for me and so many other oncologists. He was an incredible figure in the European landscape, and he's going to be elected president of ESMO for the next year. An applause for the ESMO elected president. Thank you. Beyond that, I think it's a mind that thinks beyond the standard. He always sees, I think, 5 to 10 years ahead of time. It's something you can do when you see the latest drugs, the drugs from the future coming in your early drug pipeline, but also when you have kind of a frame of mind that allows you to see the patterns evolving. And so we're going to try today to kind of understand what patterns are here that tell us what's going to happen 5 and 10 years from now. Maybe 10 is too much, but at least 5 years from now in breast oncology. So, Giuseppe, thanks for joining us today for this podcast.
Thank you very much for the invitation. Absolutely. It's a pleasure to be here with all these people. The aperitivo was excellent in Milano. So it's very easy to walk here because the environment is like in Milano, in Miami. Absolutely. It's very, very similar.
Yeah.
So let's start from this. I think there is something that is the present and the future together. And I think we saw it unfolding together because when I was still in Milan with you, we did see a couple of drugs that showed incredible activity, even more than we would have hoped. These drugs were collectively defined by 3 letters, ADCs, antibody drug conjugates, and you've developed dozens of ADCs for breast cancer and many other diseases. What have you learned, and what do you think is going to happen over the next 5 years with ADCs in breast oncology?
So the most important thing is that finally we have drug with a very high therapeutic ratio. So it's unusual to see drugs in which response rate can be close to 80%, median progression-free survival more than 3 years, dramatic impact also in overall survival for some of them. So of course, what is going on actually is to move all these agents in the early setting. I mean, neoadjuvant and adjuvant setting. And what will be challenging, I believe, in the future is what to do after you progress to the first-line setting or the neoadjuvant and adjuvant setting. Because when you have drugs so powerful, it's not so easy to understand how the biology of the cancer cell will change after exposures to this type of treatment. So the most challenging question we will have for the future, and here I believe we need to generate a new generation of agents, is what to do in those patients with cancers resistant to ADC. Main question will be how to treat a residual disease following a neoadjuvant treatment with an ADC, or how to treat a resistant disease progressing to an adjuvant ADC. And here I believe the key point for all the pharma companies that are here today is to develop new agents that can target the pathway that are based on the resistance to the specific agents. So to come to the proposal is we need to study the biology of cancer cells that are resistant to ADC in order to better address the pathways and to have a biology-driven approach in this type of disease. Personally, I believe one answer can be here, new generation tyrosine kinase inhibitors. I mean new tyrosine kinase inhibitors, not the ones that are available today. And the second one, in which I strongly believe, can be the bispecific, targeting at the same time 2 pathways, and the bispecific conjugated to new generation payload.
Yeah.
Because actually what we are missing in a plethora of topo 1 inhibitors is a new ADC with a different payload that are capable to target different cancer cells. It's a little bit complex, but this can be what we have to do in the next 5 years.
This makes a lot of sense. And it sounds like it's both an opportunity and a challenge.
It is.
The opportunity is to actually use these amazing ADCs not to palliate metastatic disease, but to get rid of it before it appears, to cure patients using it before surgery or after surgery. We know that it's already happening in the HER2 positive disease, but HER2 positive is 15 to 20% of patients. The largest proportion, 80%, still do not have ADCs with proven benefit for their disease. For triple negative, we're seeing neoadjuvant and adjuvant trials with TROP2 ADCs, drugs such as sacituzumab govitecan, darapotamab deruxtecan, sacituzumab tirumotecan, and others. And I do think they're gonna get there, as we discussed. But what about HR positive? So that's the largest proportion. Jason, do you think that ADCs will also have a role there for the largest proportion of HR positive?
Definitely, definitely. I think that we're already making big strides, especially when we look at the HER2 low, ultra low, and now with the Destiny Breast 15, we're gonna look at the nulls, right? If you can see that the ADCs like TDXD are working against those, so it opens the whole field for the hormone positive, regardless of their HER2 status. They can start benefiting from their ADC, and they are today. And also they're looking at other targets like HER3, for example. It's one of the attractive targets that are very interesting in hormonal cancers. But with all those ADCs coming, Dr. Curigliano, I just want to let you know, our audience usually when we started that was supposed to be community oncologists, but then we saw an overwhelming uptake from the patient community, the advocates and all that. But there's one question we always get, and that was, we asked people to ask us some questions to ask you today. One question we always get, that there is a lot of ADCs right now. How can we give them? I want to take you to the metastatic setting. For patients who are metastatic that qualify for multiple ADCs, how are we going to do it? How are we going to sequence them? Are we going to do ADC after ADC, or are we going to do what Paolo famously coined as the sandwich approach? You do an ADC, you give chemo, then you give an ADC. Is it truly a surface antibody issue or a surface epitope issue, or is it a payload resistance issue? I really want to get into your brain and understand that. What would you be doing?
In the metastatic setting, we have maybe to change the way we approach the metastatic disease. To be honest, the more rational way to design the sequencing trial, in my opinion, and maybe to give insight on how to sequence these agents. Now we know perfectly which is the median time to progression with anti-TROP2, anti-HER2, also anti-HER3, since some registration trial are ongoing. So once we know response rate and median progression-free survival, the only thing we are missing is who are the patients who will progress earlier. And so what we can do maybe in the future are adaptive trials in which you test also with liquid biopsy circulating tumor DNA in this patient population. And I am almost sure you will identify some patients with a ctDNA clearance for which you can prolong the exposure to the ADC indefinitely, but many of these patients maybe will not have a ctDNA clearance. So it means that here you need to test which is the best strategy.
Okay.
And so you can intercept the progressive molecular disease with chemotherapy, or you can test with another ADC to understand if you can, of course, overcome the mechanism of resistance. So why I am telling this? Because we are going to change the RECIST criteria. And so liquid biopsy and circulating tumor DNA will be incorporated in the RECIST. Because this is important for the early setting, but is also important, maybe more important for metastatic setting.
And so for lobular breast cancer.
Yes, not only for lobular breast cancer, I believe
have to
for
bring
any
it in.
disease. But the best way to better study sequencing is to use ctDNA as a surrogate with the super sensitive methods that we have today, you can really get many response before checking for the radiological response.
I love it.
amazing.
That many talk of the new TNM, that is TNMB.
Yep.
So tumor size, nodal status,
Yes.
metastasis,
Yes.
and blood.
Yep.
What is
Yes.
in the blood?
Yep.
And I do think that's important. And I think this also allow us to get to another
We need
topic.
just to translate the knowledge in the pathology disease directly
Right.
to the
100%.
solid tumors.
Minimal
100%.
residual disease.
Yes.
Yep.
And then I think beyond the blood, we're also learning to understand better the tissue. There are so many novel tests that allow us to quantitate, for instance, targets better. Because
Yes.
HER2 immunohistochemistry, TROP2 immunohistochemistry have proven challenging to
Yes.
predict ADCs, but novel assays may help. What are your thoughts?
Now, I believe multiplexed analysis, so assessing many biomarker at the same time is feasible now.
Yeah.
We have many applications in immunotherapy response, but also in ADC response. And I believe that generating many data from multiple cancer centers with the use of artificial intelligence, you can really elaborate and define algorithms
Yep.
to predict the super responders and the less responders
Yes.
to treatment. Because the real challenge for the future is to study the outliers. In the cancer patient population, you have poor responders, exceptional responders.
100%.
And I have personally some patients that have been cured in the metastatic
Yes.
disease.
Yes.
Exceptional responders. So we need just to focus on these two extremes
Yeah.
to better understand where we have to move in the future.
to that-
are few patients, but you can generate a lot of
Yeah.
information.
I want to ask you a question. I clearly, vividly remember when you presented the Destiny Breast 06 on the podium, and I was standing there, and you introduced to us for the first time the ultra lows. And the ultra low is basically any membrane staining for somebody that we call zero qualified, right? So I was standing there and I was like, okay. And then you showed the slide showing that if you include the lows and ultra lows in the hormone positive, you're including almost 90% of the patients. I was like, why don't we just give it for everybody? Why do we have to do this extra testing and spend so much money on testing and retesting sometimes? Why don't we give it to everybody? So that goes along the question, do we really need to go granularly and get this next generation test that's going to cost probably a handsome money to run? Or should we just give it to everybody and then see who doesn't respond and move on to something else? What do you think?
No, I think personally that the magnitude of a clinical benefit for any single agent, when it is a targeted agent, can be assessed by the level of expression of a target.
Okay.
If you just check in HER2 positive disease, the hazard ratio for HER2 3+ is 0.4. For HER2 low is 0.6. For HER2 ultra low is 0.76. So it means assessing the level of expression can better personalize the treatment.
Okay.
I agree with you that overall there is a benefit in the overall population. But when a patient is asking to you which benefit I am going to derive in terms of response rate, in terms of median time to progression, and in terms of quality of life, you have to be honest with your patient, and you need a biomarker to better define which is the benefit. Let's talk about the ASIAN-7. Nobody was expecting that was a negative trial. I was in the steering committee. Believe to me, our idea was outperformance of SACHI in the early line. We saw the TROPiCS-02. So why ASIAN-7 failed to demonstrate a median progression-free survival benefit, despite the patient population was very well selected according to tumor burden, according to lines of treatment. So is this correlated to the level of expression of TROP2? We are going to assess this. Or is it correlated to a different patient population respect to the Destiny 6? Because, across trials, you have different type of patients that can justify also the results of a trial.
That's so relevant. But I would say at least now we have many options in a place where we didn't used to have many options 5 years ago. ER-positive metastatic breast cancer, we have T-DXd, sacituzumab and Dato-DXd, plus all the things that are coming. And talking of things that are coming, there is this kind of huge movement, evolution that is happening in these days. There is another class of drug that doesn't come with 3 letters, but 4 letters. SERDs.
SERDs.
SERDs. Everybody's talking about SERDs. why is everybody talking about SERDs, and why did they succeed so well in the metastatic setting, and now also in the adjuvant setting where that was not fully expected in the way we saw it? What's going on there, Giuseppe?
Well, I believe this is really a revolution because personally, I believe you can omit maybe CDK4/6 inhibitors in some patients that are going to receive oral SERDs. In the study with giredestrant, this is very clear because if you check the patient population with N0 and biological features of high risk, I mean G3, or eventually G2 with a little bit larger tumor, in the event-free survival, the curve are clearly overlapping with the patient population of the NATALEE, in which you need 3 years of CDK4/6 inhibitors. So personally, I am really not surprised about the benefit of these two trials because the studies are very well designed. Oral SERDs are superior to aromatase inhibitors, and we know this already from the studies in the metastatic setting. And personally, I believe that the trials with the switching strategy will demonstrate exactly the same benefit. What I expect from the new generation of oral SERDs is to have less toxicity with respect to aromatase inhibitors. I was very surprised about the results of giredestrant, because if you check in terms of bone on joint pains, in terms of hot flash, there was no difference between an AI and the giredestrant data. And if you move to the SERENA-6, even if it's a metastatic setting, the quality of life is much more better in patients receiving camizestrant versus patients receiving an AI. So this is a critical question because we have millions of patients around the world receiving an ovarian function suppression plus an AI or an AI for the early cancer setting, and the most complaint of these patients is the quality of life, because it's horrible, the quality of life with these agents. So welcome to all the oral SERDs, not only in terms of benefit, but also in terms of...
I love this. Life. Welcome to the oral SERDs.
And I have to ask you this question here. Do we really need to do ovarian function suppression when we give an oral SERD?
We will do a trial on this. There will be a trial, a window of opportunity trial in which an oral SERD will be evaluated alone or in combination with ovarian function suppression. Personally, I believe in the premenopausal setting, if you reduce dramatically the estrogen level, this per se will have a therapeutic effect. This is my understanding. And I believe if you check the data of the soft and text, in which there is one arm with tamoxifen alone and another arm with ovarian function suppression and tamoxifen, the performance is better with ovarian function suppression. I don't know if maybe we need to use antagonist agents in the early breast cancer setting to extrapolate some agents used in prostate cancer, also in the breast cancer field. So we need to work a little bit more in this patient population with a more biology-driven approach rather than add-on approach.
Makes sense.
For sure.
So just to do a recap of the SERDs that are available currently, we know that elacestrant was the first oral SERD approved, the first new endocrine agent approved in 20 years. Then imlunestrant was also approved. We have several positive phase 3 trials. We have SERENA-6 positive for camizestrant, phase 3 trial based on ESA1 emergence, talking about biology. We have a positive adjuvant phase 3 trial with giredestrant. We have so many ongoing trials. We have vepdegestrant also, a PROTAC that has positive data. A lot is going to happen in this sense. But since in this podcast, and I'm not sure if we prepared you already, but we ask the tough questions. The tough questions. Soon we're going to have in the second line, after CDK4/6 inhibitors, we're going to have monotherapy with a SERD or combinations. How are we going to navigate this? How are you going to navigate this, Giuseppe?
Ideally, if you have the opportunity to use oral SERDs in the second line, independently of ESR1 mutation, because we have to remember that for elacestrant, there was a dual primary endpoint, intent to treat and ESR1 mutant. And the trial demonstrated superiority for both endpoints.
100%.
So this is important to remind this, because an oral SERD can work also in a patient population without ESR1 mutation. It's a matter on how you design this trial and how you select the patient population. So personally, in my ideal world, I would like to use the oral SERD together with the targeted agent. Not only in the patients with ESR1 and PI3 kinase mutation.
All comers.
Ideally in all comers.
Yep.
I know that we are not doing this because the academic community insisted in this biomarker-driven approach.
Yep.
You know, you progress, you need to test, and then you select the treatment. But believe to me, I have some patients with dual mutation, and I treated them with an oral SERD, an PI3 kinase inhibitor, or an AKT inhibitor. They are super responders.
Yep.
I have some patients since 3 years on a combination like this. So it's important, again, okay, there is a regulatory aspect, there is a payers aspect, and then there is the way you treat the patient in order to personalize the best the treatment. We cannot do this, but in an ideal world, maybe we would better.
I wanna to use your crystal ball right now. You talked a little bit about Serena-6 and the moving to another line of therapy based on molecular progression rather than radiological progression is truly an attractive approach. But if Serena-4 comes as a positive study showing that from the beginning, using an oral SERD plus CDK4/6 inhibitor improve outcomes, will the Serena-6 approach still have a role?
Personally, I believe no, if the Serena-4 will be positive frontline, because anyone will use, of course, camizestrant on the frontline setting. But the Serena-6 was a visionary idea to intercept the molecular progressive disease and to generate a science-based evidence that intercepting the molecular progression can change the outcome of the patient. The Serena-6, even if many people believe it's not an important trial, for me is a real important trial, because if you will extrapolate the data of the Serena-6 in the high-risk early breast cancer setting, you can make an impact, potentially.
100%.
So I am almost sure that also in solid tumors, intercepting early progression can impact on the long-term or median progression-free survival. And don't tell me that you need to test a lot, because 51% of the patients in the Serena-6 were positive for ctDNA on the first test.
100%.
And this is really important to be reminded when we discuss about the data.
Yes. But does that mean we should have started checking earlier on those patients?
Yes.
Right?
But you know, we are launching now a clinical study across disease in Europe to understand in the adjuvant setting how many patients are positive on ctDNA. A new generation test, let's mention Personalis to give an example, can really intercept ctDNA with a super sensitive methodology. Also very low level of ctDNA. And this will be very important in the future, because if we believe really we can cure some patients, the only way to proceed is to integrate technology with the best treatment option.
For our audience that don't understand what we talk about ultrasensitive, right now tests look at what we call ppm, or part per million. So basically how much cancer DNA we can find in a million of a sea of healthy DNA. Currently, the first and second generation tests that are MRD tests look in the order of 100 part per million, meaning they can detect something in the order of 100 cancer DNA in a sea of 1 million healthy DNA. The ultra-sensitive can go down to 1 part per million. So they can find if 1 fragment of cancer DNA in a sea of million fragments of healthy DNA. And these are the exciting tests that are coming into the market, right?
I completely agree. And don't forget that we are approaching now a revolution also in the science field that will be the quantum technology. Because nobody's speaking about this, but I was at Davos this year in the World Economic Forum, and there was an entire session on quantum technology. United States are beyond the limits actually on this. Quantum technology will transform the way we use the computer and the way we will analyze the data, believe to me. I believe there will be a dramatic acceleration on innovation that you cannot imagine in any field, including the scientific field. I hope to be alive to see this. I hope to be alive, but this will be a dramatic revolution in drug development, in understanding better what is the biology of the disease, maybe at the atomic level, and not the DNA level. So, and this is not let's say, looking at the future like Back to the Future. I believe this is already reality in some fields, because many people are investing a lot on this, and we will be surprised about this.
Yeah.
Well, this is fascinating, especially because what we hope to achieve is really precision oncology. Nowadays, we layer adjuvant treatment on adjuvant treatment, hoping to have a statistical benefit, and this helped to cure so many more patients from cancer with adjuvant endocrine therapy, CDK4/6 inhibitors, SERDs, ADCs, so many new things. But what we hope is that we have novel assays powered by AI, quantum technologies, to identify each patient's, what kind of tumors they have, what is driving those tumors, which drugs we need to give to each patient. And I think we're getting there with all the technologies we have. It's gonna take some time, of course.
Yeah.
But talking of time, we thought of, we came out with your crystal ball. Let's use it again. And you are an early drug developer. You take drugs that do not have a name yet. They're called NBK546. But this allows you also to see what's coming. And I think there's been at least 2 big revolutions over the past couple of decades. Let's say the last decade, the immunotherapy one, now the ADC one. Targeted therapies have been for longer, but what do you think is the next big thing? Is there something you are sensing, apart from quantum technologies, but some drug class that you're very excited about and that you think has a chance of being the next big thing?
So first, the bispecific. I really believe the bispecific alone can really make a difference in some disease. The bispecific conjugated with the payload, the FC fragments with a technology that can give a payload with a very small antibody that can have a higher therapeutic ratio. And finally, believe to me, I strongly believe that molecules like Radzaport interfering with the DNA repair in a different mechanism with upregulation of specific proteins can make the difference in some disease. Then there is the wave of radioligand therapeutics.
That's so exciting.
And believe to me, what I saw in prostate cancer potentially can be translated also in breast cancer. Because the approach here is completely different. Rather than thinking in a chronic treatment with exposure for years, you can think, okay, let's give 6 administration, then we stop and we don't do nothing. Or you give a maintenance with an endocrine therapy alone.
Amazing.
So we don't have to under-evaluate the radioligand therapeutics specifically with the alpha emittent particles.
The most potent
this will be the real
100%.
revolution. And finally, beyond this, if you check what is going on in hematology, advanced therapies, using a viral vector to incorporate in tumor DNA and re-express specific proteins. This is already reality in hematological disease. And someone is starting to do something also in solid tumors. So these are the major fields where I believe there will be something transformative in the future.
So I want to ask you one more thing to that. Since I started the field of medicine, people have been interested in vaccines, right? And now, because of during COVID, something happened like that was magical. We accelerated vaccine development during that phase, and then there was the interest of doing cancer vaccines. What do you think the future of cancer vaccines is going to be? And do you think there is a future for it in breast oncology?
My first 2 original publications were on 2 studies on cancer vaccines that were peptide vaccines.
The first of 500 publications. Let's say it for our audience.
But I believe personalized cancer vaccines will be breakthrough. Just to explain to the audience, you sequence the DNA of the patient and the tumor. With bioinformatic algorithm, you identify the potential drivers, and then you build an mRNA vaccine specifically for that patient. An approach like this, personal, I believe, can be transformative. The technology and the time to develop a vaccine like this is very complex. And I don't know how many companies are available to invest in this field, because if you check what is happening now, the huge investment is only in immunogenic tumors. I mean melanoma, lung cancer, renal cancer.
Yeah.
This can be an ideal approach to residual disease also in triple negative. And there was an idea to do this, but finally the cost was so high that they invested in other disease. Vaccines, I believe, can be a field to personalize the treatment on the single patient.
Yep.
And this is so important. Like, we committed never to forget triple negative breast cancer, the hardest to treat subtype. And I do think we need better drugs, hopefully vaccines that work for that. But I think this episode wouldn't be complete if we didn't also utilize your experience, not only in developing drugs, not only in treating patients with cancer, but also kind of training the next generation of leaders in oncology. And I think you did this in several ways, in multiple ways. You multitasked in your life. You train folks like me and dozens of other oncologists. And then you expanded your effort. You're going to be the next president of ESMO, you're president-elect. And so how do you see this additional effort that takes a lot of your time, of course, in training, in mentoring, in sponsoring, in helping people, elevating people? How do you see this important? How do you think it's going to shape society and oncology in the future?
You know, I personally believe that to build a better society, you need to give space to the younger generation. So I grew up in a generation of young people in which no one of us had the opportunity to be exposed to a larger audience, because the older generation was there until 75 years old. And so I say that the best way to guarantee the future of the new world is to give exposure to younger people. You know, you can train 10 of them, but maybe 2 out of 10 will be outperformers, will be outlier. In the future, they can be the next generation of leaders in oncology. So what I would like to invite all of you in any single country where you live, because this is not a matter only of Italy, but also in Egypt, in Saudi, in Latin America, in Asia, there will be a huge number of young people that need just an opportunity. You don't lose nothing giving an opportunity to a young man. Yeah. So I remember with Paolo when he wrote the first review on ADC, that was a blockbuster. So you don't need to have a first authorship to be recognized. But if you give a first authorship to a younger man or woman, you will give an opportunity to that one. 100%. It will grow, and they will support you also for the future. So we need really to invest on the younger generation all over the world, and to give opportunity to anyone. The world is rapidly changing. Yeah. It's, we know what is going on. But for a better world, the best way to proceed is to invest in the younger generation. I did this scientifically, to be honest, because I said, if you don't give opportunity to these people, there will be no future for oncology for your country. And then this model was replicated in Spain, in France, a little bit less in Germany, but personally I believe can be done all over the world, because I really believe that this is the best way to give a chance to the world. Yeah.
I really think you're a global model for this. I think many have been inspired. My life has been changed.
I want to, along those lines, you know, I was really impressed about the growth of ESMO. ESMO is really now not only a European society, it's a world global society. Your footprint in Asia is remarkable, and now your footprint in Latin America, also in the US. And I heard recently, because I had 2 trips to the Gulf region, that you are expanding ESMO to that area, and they're super excited about it. What can you tell us about the future of ESMO, and how do you foresee it now that you are president-elect?
Well, you know, first of all, 57% of members of ESMO are under 40. 34% of ESMO members are from Asia or Middle East, so more than European. If you want to be a global society, you need to give space to other parts of the world. You know, in the Middle East, you will be surprised, but there are 100 million people in Egypt, something like 300 million people in the North Africa, and then if you move in the Gulf area, there are millions of people also over there. And I really believe that launching this summit in the Middle East, that will be the MENA summit, will give a lot of chance to younger people to have an exposure. Because when we do a meeting in Asia, like ESMO Asia or Latin America or Africa, because we did the meeting in Cape Town, 80% of the faculty is a local faculty.
Yeah.
And only 10% of the faculty is from Europe. And just to be clear, we don't take money from this meeting. We invest in the meeting and we pay for everything.
Amazing.
This is important to be known.
Yes.
Because there is no commercial interest from ESMO to do a meeting in Asia or in Latin America or in Africa or in the Middle East. It's a way to expand, of course, the importance of clinical oncology and clinical research in the MENA area. Now you have excellent oncologists. You are start doing a lot of registration trial. And I am sure that if we will go there, many other centers will be open to clinical trial. And opening clinical trial means access to innovation to many patients and means impacting on overall survival of that patient.
For sure.
This is you have to think about this.
For sure.
Yes.
This is so meaningful.
That was such an amazing episode. We're gonna love this one. It's gonna be one of the landmark episodes we're gonna keep referring to. We really want to thank you for joining us today.
Thank you for the
I want to thank all our audience for being with us and all our guests today here. Beautiful Miami, beautiful episode. And it's always wonderful to share the stage with my best friend over here, Paolo.
Thank
Paolo,
you,
any last
Jason.
words?
Thank you, Giuseppe.
Bravo.
This was awesome.
Thank you.